Welcome guys to this session of NEET PG Recall 2023, where we will be discussing questions from anesthesia. My name is Dr. Vinish and I'll discuss the anesthesia questions with you. So when I spoke to the students and when they told me on the various groups and messages that I got from them, for the number of questions that came from anesthesia ideally were two direct questions that they felt, that too from CPR and image-based questions. And the other important topics like propofol, IV drugs, pharmacology is where most of the questions were kind of omitted or not directly asked from there. It's from what I got to know from the students. When I went to the paper and when I got to know the other questions also, what I did was steal some questions. Some other branches steal. But more than steal, what it made me realize was this is what they have done this time around, that just from NEET PG pattern, they are going towards the next pattern in terms of questions, where you will find a lot of questions were integrated, and all of you would agree with me on that. Integrated in the sense that I could find a lot of questions from anesthesia to be a part, a little bit of gynac that I'll discuss with you, a little bit of ENT, which was there, physiology, right? And even surgery, I'll add to it, apart from the anesthesia point of view. So like these were the integrated questions that I could think from anesthesia. Apart from that, I could also feel that in fact, biochemistry and pediatrics had a lot of integration between them, even medicine, pharmac, and physiology. So hopefully all of you would agree with me on that. The fact that, the questions were all sort of integrated. A lot of people expected, some of them could find the paper easy, some people found it tough. But let's go ahead and just discuss. Now things are over. Let's just discuss those points out. Okay. So let me start with the first question. All right. And these are the ones, let me tell you before I start, is the questions from which I got to know one or two options. The remaining third and the fourth options were not clear. So a lot of places I have put my own options, right? Just to make them a question, right? Please remember that they may not be the same thing as they've come in the paper. I put my own options over there. At the same time, just to make some questions more anesthesia related, I've changed few things, and I'll tell you what I've changed from what the students told me. So they will all seem relevant to anesthesia, and we will discuss that though being integrated, how are these questions related to anesthesia or relevant to anesthesia. Let's begin with the first one. So a 33-year-old female patient was undergoing hysteroscopic polypectomy under general anesthesia. This word general anesthesia was not given in the exam. That's my addition to make it anesthesia oriented. Okay. So exam question was patient of hysteroscopic polypectomy. So I've just made it more clinical and added the word of anesthesia. 33-year-old female patient undergoing hysteroscopic polypectomy under GA. During the procedure, the fluid deficit was found to be 2000 ml. Which of the following is the biggest risk for this patient or the patient in this condition? Like in this condition where the patient is undergoing hysteroscopy polypectomy and the fluid deficit is 2000 ml, right? We'll discuss what this fluid deficit is, and the options given in the exam, these are the same ones which came in the exam: DIC, acute tubular necrosis, pulmonary edema, and thromboembolism. So which one is the correct answer here? Which one of the following is the biggest risk for the patient in these circumstances, in this condition? So according to me, I may be wrong also, we just share the knowledge that we have. According to me, the correct answer here should be pulmonary edema. Yes, a lot of people might disagree with me also. Some people might think otherwise, but now the correct answer here according to me is pulmonary edema. This question is a common question now between anesthesia and gynac. And guys, believe me, this procedure day in and day out is done under anesthesia in the OT. And day in and day out, all the anesthesia people are worried about the fluid deficit, including the gynae people, because as soon as the hysteroscopy is over, not just the anesthesia people, but even the gynacs, the first thing they ask to the technician in the OT, and I'm not saying in India, even abroad, the first thing asked to the OT technician is how much is the fluid deficit? What is the meaning of fluid deficit? Fluid deficit means how much fluid has gone inside, how much fluid has come outside. So the point is, are we aware what is hysteroscopy and how it is done? So let's see what is hysteroscopy, or is it the same thing as laparoscopy? So this is what is called laparoscopy. Laparoscopy is when you have insufflated the stomach with the gas. Right now what we are using is carbon dioxide, right? It's insufflate because with the insufflation, the stomach gets inflated, and then you are seeing everything on the screen and the surgery takes place on the screen. This is what is called as laparoscopy. Laparoscopy. So there is laparoscopy, gallbladder removal, laparoscopic, uterus removal, or laparoscopic salpingectomy, or even laparoscopic abdominal surgery is done nowadays, right? Even hernia repair is done laparoscopically. This is what is called laparoscopy. So what is hysteroscopy? So in the laparoscopy, the scope is put from the tummy, from the stomach, once the stomach is inflated with the gas, and then under the visualization from here, you operate it out from the screen by looking it over the screen, right? Anesthesia people do the same thing when it is fiber optic intubation. So we put a scope from the nose or the mouth and we look at the airway and the larynx. It's like a bronchoscope and we see it on the screen. So laparoscopy is almost the same to that. It's from the abdomen. What is hysteroscopy? The same scope, sort of the scope is taken, but instead of going from the abdomen, they have gone from the vaginal end. So once you are going from here, basically, so with that, what you're doing is, in case of a polyp gets removed. In case there is a myoma, sometimes myomectomy is done from there. So to visualize the uterine cavity, in fact, nowadays, even for IVF pregnancies, before they start the IVF pregnancy, a hysteroscopic visualization is mandatory. So a lot of people who are unable to conceive before the IVF, hysteroscopy is being done. So what is exactly in a hysteroscopy that they do? In a hysteroscopy, what they do is basically, you people have not, you must have heard of TURP, transurethral resection of prostate, not in women, that is done in men. So which is done in men, right? So when they are having prostate enlargement, so transurethral resection of prostate is almost the same thing like this, like the hysteroscopy. They are doing the same thing. The fluid goes inside, right? So they put the fluid inside. In the TURP, it's again done the same way. So fluid can be normal saline or it can be glycine, right? That fluid goes inside, it dilates the cavity, and from that they try to see it on the screen. And on the screen, if there is a polyp, they try to remove it. If there's a myoma, they remove it. Or in case of an IVF, they are trying to do an IVF, then they just look at the cavity, right? So this is what is hysteroscopy. Point is, fluid is going inside, continuously fluid is going inside from here, and that fluid is kind of dilating the cavity, makes things easy to see, and the fluid gets dilated, and the same thing, the visualization becomes easy on the screen. Whatever fluid is going inside at the same time comes outside, and it keeps on falling either on a bucket, on a ground, and the fluid coming out is always measured. So this is not the IV fluid I'm saying. This is the fluid which is pushed through the vagina into the uterus, right? Through the opening. So the opening below is being pushed into the uterus, right? Just like TURP is done in men. So this uterus visualization is done, fluid goes inside, and after that, the fluid which is coming outside, right? So when the fluid which is coming outside, that is also measured. So now what happens is, you measure the amount of fluid which has gone inside the uterus and the amount of fluid which comes out of the uterus. If there is an imbalance in between the two, it means the fluid has got absorbed in the body. So if you find there's an imbalance between the fluid which has gone inside and the amount of fluid which has come out, it would lead to an imbalance, right? So imbalance means where has the fluid gone? If it is not in the uterus, it has not come out of the body, means it has got absorbed in the blood, right? There might be opening blood vessels over here which must have got opened, and the fluid has got absorbed from that. Once it's got absorbed, what has it done? It's gone inside the circulation. Once it has gone inside the circulation, what will happen? The interstitial fluid will get increased, and ultimately this can lead to pulmonary edema, right? And that is the answer that we are looking at. Okay, so the correct answer here becomes pulmonary edema according to me. It is not DIC, it is not acute tubular necrosis, and not thromboembolism. Can it cause embolism? Yes, embolism is a dreaded complication. Embolism is a dreaded complication that can take place during hysteroscopy, and that suddenly the patient might die on the OT table. It's a dreaded complication. It can take place. But once the fluid deficit is what they're talking about, then it is not embolism that we are referring to, right? So when you speak of a process called hysteroscopy or laparoscopy or any process like that, so all of them are going to have complications. So all of them will have patient positioning problems, especially in hysteroscopy, because the position is lithotomy, which is done. It has its own problems. Anesthesia related complications, because some people give GA. This process can also be done under spinal. People who have attended my lecture know that this can be done under spinal also. But sometimes GA, sometimes spinal. Some people put laryngeal mask, airway. Some people just do it on bag mask ventilation if you're doing a GA, right? Then these are the problems related to positioning and anesthesia. Apart from that, there are other complications that can take place, which is like cervical trauma, like creation of a false passage. There can be perforation of the uterus, intraoperative bleeding. There can be embolism which can take place. As I said, embolism is a dreaded complication. And not to forget the fluid overload. The fluid which is going in from here and the fluid that is going to come out, that has to be equal, and the deficit should be less. If the deficit is more, like how it has been given in the answer, like 2000 ml is huge amount of deficit, this has gone into the circulation and this leads to pulmonary edema, right? This was a chori wala question, but it's correct. It's a part of anesthesia also. Day in and day out, we are also worried in the OT about the same thing. Whether the patient might have pulmonary edema or not. Second question, similar question, hence I included. It's a similar question based to what we have discussed right now. A 40-year-old patient, it's not exactly the same words, right? This is not exactly the same words which have been asked in the exam, but I'm just discussing it out with you. A 40-year-old patient was given 4 units of blood in 4 hours. He started to have respiratory difficulty. On auscultation, it was found he had bilateral crepitations. Which of the following is the most probable cause of his condition? As soon as you read the question and you don't even know the answer and you haven't read the options, the first thing that comes into the mind is acute lung injury straight away, without even thinking anything. But that's exactly why you should go through the options. So if you go through the options of this question, there are 2 or 3 which I know, one may be wrong. So one, anaphylaxis, fluid overload, acute pneumonia, acute lung injury. So anaphylaxis, if someone is being given blood transfusion, like 4 units of blood has been given in a period of 4 hours, anaphylaxis should have occurred according to me immediately, right? After 4 hours, see, remember, I'm just sharing my knowledge with you. I may also be wrong. You may correct it later on, right? Anaphylaxis should have happened immediately in the patient. Now, so I think anaphylaxis is ruled out. If you have given 4 units of blood in 4 hours, right? Ideally, what we try to do is give 1 unit of blood in 2 to 3 hours, right? Not even 4 hours, 1 unit in 2. If it's okay, unless and until some emergency needed when the patient has lost 2 to 3 liters of blood. And in that case, massive blood transfusion is needed in the patient, right? So if you're not doing a massive blood transfusion, normally what happens is 1 unit of blood is given to a patient within 2 to 3, sometimes people even mention 4 to 6 hours. Like slowly it's given, slowly. Blood isn't given very, very fast to any patient, never. Here you will realize 4 units of blood have been given fast to the patient 4 hours. What is the reason? That has not been mentioned. And then he has respiratory difficulty based on that and bilateral crepitation. So yes, fluid overload may be one of the options. Now, after 4 hours, if the 4 hours before that patient is fine and suddenly within 4 hours patient develops pneumonia, less likely. And patient is not giving a history of fever from the question that has been mentioned. Fever was not mentioned in that, right? And the same thing holds true for acute lung injury, because this was the first doubt which came to my mind. Yes, it should be acute lung injury. But again, guys, because fever is not given, so acute pneumonia and acute lung injury is something which I will rule out. So what should have been the correct option here? Again, just like pulmonary edema, I'll rather put it and go for my option. Like I'll put my stakes on fluid overload, right? This is another question which was asked. So 4 units of blood given in 4 hours, patient starts to have respiratory difficulty. On auscultation, it was found that the patient has bilateral crepitations. Which is the most common cause? I don't think it is anaphylaxis. I don't think it is pneumonia. The 2 options where you could have been confused is fluid overload and acute lung injury. I totally agree. Here, this is circulatory overload happening because of acute transfusion, right? And acute lung injury, what is called as transfusion-related acute lung injury. Even this can be there, but the only difference is between fever. So when you're giving blood transfusion, there are lots of reactions which can take place, right? There can be immunological reactions. I'm not going into details. So now again, if I have to discuss this question, if you see blood transfusion becomes a common question between medicine. It can be a question from surgery. It can be a question from orthopedics. It can be from anesthesia and emergency. So do you realize all the branches come into, in fact, even pharmac. Let me take even pharmac. Why not include pharmac here? So again, it sort of becomes an integrated question, a general question. Whether you're working in any branch, you should be knowing this answer. If you're working in anesthesia, you should be knowing this answer. If you're working in medicine, you should be knowing this answer. In fact, even if you're working in gynae, you should be knowing this answer. Why to leave away the gynae people? So therefore, everyone who's working, I mean, everyone should be knowing the answer. I'm not denying that. But from what it has not come directly from one branch, as one would say. So basically, I feel the correct answer is fluid overload. So when we speak of various complications that can take place, so they can be divided basically or roughly into 2 types: immunological, right? Immunological reactions that take place, and second is the non-immunological. I'm not discussing everything in detail. I'm just discussing in short, guys, right? So in the immunological, you will have those hemolytic transfusion reactions, there can be those allergic reactions, febrile reactions, and the lung injury, acute lung injury that takes place, which is what I am thinking about. All of us get confused with that. Delayed would be again hemolytic transfusion reactions and trost transfusion purpura that takes place. So these are the immunological. Non-immunological would be volume overload, citrate toxicity, hypothermia, bacterial contamination. Yes, bacterial contamination can take place, but it will take time to develop, not immediately within 4 hours, right? And infectious disease transmission, this is delayed non-immunological reaction. So out of all the options that were given to us, according to me, the correct answer should have been circulatory overload. Remember, if it is an acute lung injury, you are going to get fever, right? Here, there is no fever. So fever has not been given. In fact, whether it is acute lung injury or circulatory overload, you're going to get crepitations, dyspnea, hypoxia, pulmonary edema, and lung infiltrates in both of them. So what is it that differentiates the two? Fever, according to me. In acute lung injury, there should be fever. In circulatory overload, there is no fever. Of course, there are changes in blood pressure also. If there is circulatory overload, you will end up with hypertension. BP will increase on a higher side. Acute lung injury would go for hypotension, right? If there is circulatory overload, there's a volume overload which is taken place, and that's exactly why people give diuretics. All of you are aware, if patient has been given 1 or 2 units of blood, always practically, some people would say give 20 Lasix, give furosemide, give diuretics. So a lot of people say there might be a circulatory overload taking place, so always give diuretics for that. But acute lung injury normally might improve, might not improve. It is inconsistent with diuretics, right? So this is the my take on the question which was asked. So according to me, the correct answer should have been fluid overload. If the options are different, then I'm not aware, but this is what I could gather from whatever the students told me and from the groups that I was aware of, right? Let's go to the next one. Again, as I said, directly propofol, thiopentone, ketamine, none of them are there. None of them. None of the questions, even muscle relaxants, cisatracurium, atracurium, none of them. Even the monitoring part didn't come directly as what it normally comes. But yes, all of them felt like an integrated question. In fact, the next one as well. This also was asked, right? Spirometry graph. And of course, you'll say, sir, this is physiology question. Why including anesthesia? I told you, I'll tell you why. It's a physio question. I'm not denying. It is physio. But that physiological part is also important for anesthesia. That's exactly why I'm saying why it is integrated, right? But this was the question which was asked. Image-based question. Kindly identify the marked point in the adjoining graph. So marked point was this much from year to year, right? According to me, and according to what the students told me, as I said, even I may be wrong, right? But from whatever we know, this is the question that we have. The options given to us: residual volume, functional residual capacity, expiratory reserve volume, and vital capacity. So what is the correct answer here, guys? The correct answer here is functional residual capacity. So what is functional residual capacity? Functional residual capacity is basically this point. But what is that point? So let's discuss it out. In short, when you're breathing normally, it is called tidal volume. Okay? Normal tidal volume, 500 ml. Tidal volume. When I take a deep breath, that's called inspiratory reserve volume. I'm also a chest physician. I'm also a qualified chest physician, guys. Apart from doing anesthesia, I'm a qualified chest physician and I've done hospital administration also. So let me speak about spirometry if I can, if I'm allowed to. Okay? If not from being anesthesia, let me speak from the chest medicine point of view. So tidal volume is the normal tidal volume we are breathing. Inspiration, expiration. Inspiration, expiration. What is inspiratory reserve volume? It's the extra amount of breath which you take with each inspiration. If you're doing a full forceful inspiration, above the tidal volume, the extra breath that we took was inspiratory reserve volume, right? Then I blew normally. That is normal tidal volume going out. Inspiration, expiration. So inspiration, tidal volume goes up. Expiration, it goes down, right? So inspiration, expiration is normal tidal volume. When I take a deep breath, the maximum, that is inspiratory reserve volume. What is expiratory reserve volume? Then when I blow maximum, when I blow more than my tidal volume, this is called expiratory reserve volume. The maximum breath is blown away. And after that, what is left inside my lungs, that is residual volume. Okay. So expiratory reserve volume and residual volume in combination, it is what is called as functional residual capacity. And this is the most important terminology or measurement because this is where the oxygen is stored in the body, right? This is exactly where the oxygen is stored. People who have got a good FRC are the people who are athletes, people who are running. You'll see them, athletic people, they are keeping on running. They normally don't get breathless. If someone is COPD, obese, this is where the FRC decreases. In fact, there's a concept clause called closing capacity, encroaching upon the functional residual capacity, which is seen in COPD patients, right? Closing capacity, which encloses upon the functional residual capacity. So FRC is where the oxygen gets stored up. It is physiology only, na? Yes, it is physio. How come and why it becomes important in anesthesia and how come related to anesthesia? So here I would like to discuss the question which has been asked before, not exactly like this, a question which has been asked before. So hopefully these points are clear to you. Functional residual capacity is expiratory reserve volume plus the residual volume. All right, that is functional residual capacity. Right, this becomes the vital capacity and this becomes the total lung capacity. So hopefully these points are clear, right? So vital capacity also I discussed with you and total lung capacity. Functional residual capacity is important in anesthesia. Forget the COPD part of it. That's the clinical part. I mean, related to COPD, which I'm not discussing here. When we do pre-oxygenation of a patient, you must have heard of pre-oxygenation under anesthesia. What is pre-oxygenation? Before giving anesthesia or general anesthesia to someone, you hold a mask for 3 minutes. That gives 100% oxygen for 3 to 5 minutes, right? So that mask, which is giving 100% oxygen for 3 to 5 minutes, and patient is spontaneously breathing. This is normally done when you're ideally doing rapid sequence induction or on a full stomach patient, right? On a full stomach patient, this is done normally at that point of time, but routinely also, a lot of people do follow it. It's always good to do a pre-oxygenation because what happens is once you're holding a mask to a patient who's awake, not anesthetized yet, so you are giving 100% oxygen to the patient. Patient is spontaneously breathing. So all the 100% is going inside. What it does is it causes denitrogenation. So whatever air is there inside the lungs, the nitrogen there gets replaced with oxygen. Hence, it is called denitrogenation, and the lungs become full of 100% oxygen. The question is where? Where is that oxygen going and replacing? It is working at this FRC, functional residual capacity. So that pre-oxygenation that we are doing before the general anesthesia is given to the patient works at the functional residual capacity, and this is where, in case of an apnea, normal patients can tolerate apnea for 3 to 4 minutes, and if you don't intubate someone in 3 to 4 minutes, straight away they are gone off, up, right? But if you have given pre-oxygenation to someone, that apnea or basically the desaturation that will take place, falling down in saturation. If you think you stop breathing for 4 minutes, what will happen? Within 4 minutes, our SpO2 starts to decrease. Think about not breathing for 4 minutes. Can you do that? Most of us, we can't. Within 4 minutes, SpO2, I mean, I'm not talking of people like Baba Ramdev and all. Yoga people, I'm not including them. No. I have no idea how much they can breathe and they can't breathe. I have no idea about them. So let me cancel them out. Okay, these people. I told you, very inspired by them. Yes. How much time they breathe, I don't know. So SpO2 will decrease for any normal patient within 3 to 4 minutes. But if you are pre-oxygenated someone, because the lungs are full of oxygen, this desaturation or fall in SpO2 will take 10 minutes. So in case you are unable to intubate someone, it becomes a difficult intubation, guys. Remember, you have 10 minutes to save the life of someone. You can do other airway maneuvers, which I'm going to discuss now. There are other airway maneuvers you can do in those 10 minutes and save the life of a patient, and hence pre-oxygenation before any surgery becomes much essential even before giving general anesthesia. Because in that case, what happens? The apnea period can be increased because the lungs are full of oxygen. Remember, this is where the oxygen is, right? This is where it is stored. I know all of you will be saying it's a physio question, but I told you its relevance to anesthesia also and why it's important. So now, this is that question. Now, which people said, sir, anesthesia, anesthesia. Yes, this was the question. I'm not saying the same image. Similar image must have been there. Some students even said, sir, image was not given. Right? I don't know because I didn't come for the exam. Even if I came, I would not remember. Out of so many questions, you people can remember. At this age, I can't. Right? So this is what the students told me. It's based on students and from what they have said. So image is not the same. But some of them said image was there. Some of them said image wasn't there. It was just written. So right, lateral recovery position or recumbent positions where the patient is there. What is indicated by this? Unconscious patient, pulse and breathing present. Unconscious patient, pulse and breathing absent. Unconscious patient, pulse is present, breathing absent. Unconscious patient, pulse absent, breathing present. Confusing, huh? This is there, this is there, this is there. Simple. Let's think. First point was unconscious patient. Yes, all of us know this is unconscious patient. So cancel it out. Right? Let's see the options one by one. Pulse and breathing present. Yes, it's possible, not possible. So let's leave it out. pulse is absent and breathing is absent, you will not sit here and look at the patient. Oh, how are you, sir? Are you awake? Are you there? If pulse is absent and breathing is absent, straight away you will jump on the patient. Doesn't mean you will jump for doing the CPR. I know what you people are thinking. CPR. Straight away you will start CPR on the patient, right? Pulse is absent, breathing absent, we straight away go for CPR. Next point, if the patient has pulse and breathing is absent, so you already know pulse is there. If pulse is there and breathing is absent, you will give a breath to the patient, and this is not a position to give breath to the patient. Am I right? If the patient has absent pulse and breathing is present, then you're not worried about the breathing. Pulse is absent, which means patient can have hypotension also. You would be more worried to secure a IV cannula, start fluids, maybe give blood transfusion, think of dopamine, think of dobutamine, think of noradrenaline because pulse is not there. I mean, of course, you will need ECG also and to see if there's any arrhythmia or not. But the whole point would be thinking that, maybe there's hypotension due to any cause, maybe there's hypovolemia, maybe it is vasovagal. Who knows? Who knows? It can be anything. I'm not vasovagal, pulse will not be absent. But anyways, whatever is the reason for pulse being absent, the point is that you would try to look into the ECG. You would try to take an IV cannula. Again, one more question is based like that, right? All are emergency questions. Huh? One is again IV cannula. And once you've taken IV cannula, you'll try to give IV fluids, resuscitate the patient, right? If blood is needed, you will give blood. If colloid is needed, you will give colloid. In case nothing picks up, you will start dopamine, dobutamine. You can give adrenaline, noradrenaline, depending on what the situation is based on ECG, right? Ultimately, ECG will become important in this situation. Now, so therefore, B option is out, C is out, and now D is out. What is left? Pulse and breathing present. This is exactly what is called recovery position. So recovery position during CPR, right? So when you're talking about CPR, let us talk about the basic life support, BLS. When BLS is being done, so this is exactly AHA, American Heart Association 2020 guidelines which are there. The first thing that you always see is go for a scene safety. Is the scene मतलब सब लोग सीन सेफ्टी देखते हैं ना, सीन सही है कि नहीं. अगर सीन सेफ नहीं तो कुछ करते क्या तुम लाइफ में? You think you're running around with someone, the scene is not safe, will you run away? No, na. Shahrukh Khan also didn't run with Kajol in Dilwale Dulhaniya till the time scene was not safe. Scene has to be safe for doing anything. Same here also. Always look at scene safety, you'll end up in trouble otherwise. Scene should be safe, right? Scene safety. Next is check for response, right? Check for response. If the patient is responding, yes, why are you troubling him? Look at him. If he's okay, then leave him there. The problem is if there is no response, then you're thinking our patient has become unconscious, which was given in the question. Once the patient is unconscious and not responding, don't start CPR immediately. First, call someone for help. Right? You call someone for help that in case there's a problem, एक से भले दो, two people are better than one. At least someone can help you out. And then you are activated the emergency response system or the emergency medical services of the place you are in. You ask them to get the automated external defibrillator. You get them to ask them to get the equipment, endotracheal tube, LMA. So this becomes more important before you do anything else, right? So the only step that you did initially was check for response. And if there is no response, straight away the next thing was call for help and ask for AED and get for endotracheal tubes. And after that is when we look at the breath and we look at the pulse. And if you find that the breath is present and the pulse is present, which means only the patient unconscious, then what do you do? So we are looking for the breath and pulse. If both the pulse is normal, if the pulse is felt and breathing is normal, you just have to monitor the patient. This is exactly where you try to keep the patient in the recovery position that has been mentioned, right? You will monitor the patient till the emergency responders would arrive and they would take care of the scene from there on, because now the patient is just unconscious, patient has normal breathing, and patient has the pulse felt. It is the answer to the question which has been asked. So this is the correct answer. Pulse and breathing present, unconscious patient, right? Now if the patient has no breath, right, no breath but pulse is felt, the next question, this was option C, this was the option C, right? This was option C that we have, that pulse is present and breathing is absent. In this case, what we need to do, you need to give breaths, because what is missing is breaths, right? Here breaths are missing, you'll keep on checking the pulse, and if you feel there is an opioid overdose, you can even give naloxone. There's again a change here, naloxone. This was added recently, was 2020. Naloxone to be given in case if it is needed, even during BLS. I'm talking of basic life support, not ACLS, right? Even here you can use naloxone, one of the drugs. So this was when pulse is felt and breathing is absent. Third, patient unconscious means no response, no breath, and no pulse. This is where they say start CPR, and now CPR is started. CAB, chest compression, airway breathing, right? chest compression, airway breathing. This is exactly what is done in CPR. There is points I will discuss a while from now, but this is exactly how CPR takes place. So basically 30:2, 30 chest compression, 2 breaths is what we are supposed to do. And after that, once the automated external deflator arrives, after that you will check for the rhythm. In case the rhythm is shockable, give the shock, and then followed by that, you immediately do not check the pulse. Once you've given the shock, remember, no pulse check. Straight away start CPR, right? And after that, you need to continue the whole cycle till the time ACLS providers or emergency responders would arrive. In case of the rhythm being non-shockable, in that case, resume your CPR immediately, right? And keep on checking the pulse in between. And once the ACLS providers are there, in that case, you have to continue, right? This is basic life support. Now, based on the same thing or a similar question was the next question asked, which was an image-based diagram. Identify the adjoining image. From here, all of the students could remember just 2 options which were given, right? The image everyone remembered, and the answer also everyone remembered. All of you have answered it correctly, I feel. But the 2 options I have added now. Okay. So for my orthopedic friends, this is question for you also. So now this becomes question of orthopedics as well, anesthesia also. Okay. Integrated questions, we are moving towards next. That's how we'll move towards next. Okay, so let me add options from orthopedics. Identify the adjoining image. Is it a cannulated screw for compound tibial fracture? Is it intraosseous cannula for fluid therapy? Is it a K-fire for tibial shaft fracture? Right, you people know that. Or is it bone marrow aspiration going on? Right, this that you see came as, all of you have answered this correctly, I know that. This is intraosseous cannula, right? Intraosseous cannula. But we would like to put it in which branch? Intraosseous cannula should come in pediatrics. Intraosseous cannula should come in medicine. It should come under anesthesia. Should it come under orthopedics? Should it come under surgery or casualty or emergency medicine? Do you realize the amount of questions, the way they have been asked in exam? They have not asked you about IV cannula. Remember, last 2 or 3 years, they had lots of questions regarding IV cannula. This time they've asked intraosseous cannula. So these are the kind of questions which are coming in exam. Of course, most of you have answered the question correctly. This is intraosseous cannula. Let me explain to you how it is relevant to anesthesia. Why the anesthesia point here? Okay. Now, before we even go forward, where are the places that you can take intraosseous cannula? So everyone knows you can take it at the tibia. So there are upper end and lower end of the tibia, both you can do it, right? Apart from that, people are also aware that you can take it at the humerus, right? So tibia, humerus is what people are already aware, tibia and humerus. At the same time, in pediatrics, it was said that you could take it in femur. But now what has happened is that under the newer things, people have said in case of an emergency, when you're unable to, get an IV cannula. For example, in emergency medicine, you're there in the casualty and a patient comes with burns, right? If a person has so much burns, and remember the burns, the first thing that you have to do is do fluid resuscitation. Let's go back to surgery. You are under emergency casualty medical officer. All of you worked as interns and post interns, right? You are working in the casualty, you get a burns patient, government hospital. You have to give fluids. Imagine in a burns patient, how difficult it is to find an IV cannula, right? Not just the burns patient, otherwise also trauma. You take an accident patient, you don't get an IV cannula. In case of an emergency, what will you do, right? So I'm not just saying burns. Like burns is one of the things. If that area, that part is not burnt, you can still go for it. But in the places where, like orthopedic patients are there, casualty patients, emergency where someone's coming and you're unable to find IV cannula and you have to resuscitate or give fluids. So yes, you can take the tibia, the proximal end, or the distal end also can be done. They say you can use the, this is the medial malleolus, so you're doing it on the distal part. You can use the distal part of the femur. You can use the anterior superior iliac spine. But now what I was saying, of course, humerus, we are aware. Even the sternum and even the distal radius is what people say, right? So these are all the places where intraosseous line can be used, right? Now what happens is once you take an intraosseous line, guys, so this becomes more like a channel from where you can give IV fluids to the patient. You can give even blood transfusion to the patient. You can give emergency medicines to the patient. Like in case this is an emergency, it's not a routine patient that you're going to take an intraosseous cannula. It is life-saving for the patient, hence you're doing it. You might have to give adrenaline to the patient. The patient is dying. Forget about the intraosseous cannula there. I mean, anything else, you just have to save the life. So adrenaline can be given, right? Vasopressin can be given, amiodarone can be given. So all these emergency medicines which are used, all of them can be given from the intraosseous line, anything that is used in emergency. So blood transfusion, IV fluids, all these things can be given from the intraosseous line. Another thing is, if one line is not working intraosseous, you can try to take it at the other sides also. But remember, this is only supposed to be done in emergency. One more point I'd like to add, initially it was started only for pediatric patients and hence it was not discussed. But recent guidelines all have said that it can also be used for adults, and let me show you the ACLS guideline now. These are the ACLS guidelines 2020. The same, when I was discussing with you basic life support, this is now advanced cardiac life support guidelines. They are saying that once you start CPR onto the patient, right? The same thing I'm continuing from the BLS that we were discussing. And remember, I told you the rhythm is shockable or not. If it is shockable, you give a shock and then start CPR. Do you see, when we speak of ACLS, means advanced life care support, which means advanced emergency responders have come. So they might be having endotracheal tube with them. They are having LMA with them. They have the IV cannula with them. They tried to put a cannula. You could not get through. In case of emergency, they immediately went and put ahead intraosseous line. Can you see that? It has been mentioned here directly in ACLS guidelines itself. If it is not an IV access is not available, go for intraosseous access. Let me even expand that a little further. Now, can you see this? So in CPR, do you see this? Intraosseous access. Similarly, if there is asystole or pulseless electrical activity, right? In this case, again, they are saying do the CPR and immediately take a IV access. If not available, go for intraosseous access. Can you see? And this is for adult. I'm not talking of pediatric. This is adult ACLS, advanced cardiac life support guidelines. Initially, this was said only for pediatrics, and that's why this becomes so important. Can you see? Adrenaline can be given from here every 3 to 5 minutes. And by then, you start thinking of putting advanced airway, which is endotracheal tube, right? And it is LMA is not indicated. Ideally, the best thing is to put endotracheal tube. If you can't use it, you can put LMA also, right? And drugs which can be used are adrenaline, amiodarone, lignocaine. So these are initial drugs which can be used, right, during CPR. Hopefully this point is clear. What we discussed was intraosseous line, and this question is intraosseous line. I think most of you answered this question correctly, so I don't think. One more point. What can be the complications of the intraosseous line? It can cause infections. It can cause cellulitis, very common. And where not to do it, contraindication. Someone has a fracture over there. It's very difficult to do it on the same point. No? That's exactly why you have to see so many other places where you can do it. It's not necessary always have to put inside the tibia. Sir said tibia, even if the tibia is fractured, do it. No, you have other places also. So that's what you're supposed to be aware of. It's a sternum, humerus, distal radius, right? Anterior superior iliac spine. There's even the distal femur. So all these places can be used in case of emergency for pediatrics as well as adults. These are the changes. Clear? Hopefully, right, guys? Another simple question coming from anesthesia. I think I discussed the same thing in the sprint session also. I mean, something similar we have discussed in CPR during the sprint sessions also that we took. So the adjoining image indicates which maneuver. The single image was given, the 4 options given then. This was the easy question. Manual inline stabilization, head tilt, chin lift, jaw thrust, and head extension. These were the 4 options given, I think. And the correct answer, even closing your eyes, you can write just by looking at the diagram. If you've not studied anesthesia, I said a mental ability test. In CBSE, there is something called as mental ability test. Even if you don't know anything, you can know there are 2 things happening. Someone is doing like this, someone is doing like this. So basically head tilt, chin lift. This is the correct answer, right? This image is indicating head tilt and chin lift. Why is head tilt, chin lift done? Remember I told you when we were discussing CPR right now that in CPR you used to start CAB, chest compression, 30:2, right? Correct. 30 means you have to give 30 chest compression. You're supposed to give 2 breaths. So 30 chest compression, 2 breath, 30 chest compression, 2 breath. This goes on for about 5 cycles in 2 minutes. This is what is done. Now the point is, if when someone collapses, the tongue falls on the posterior pharyngeal wall. So this is the trachea. Let me change the color of the trachea. This is the trachea, right? Behind the trachea, we have the esophagus. Oh, esophagus is the same color. Let's change the color of esophagus. This is esophagus, right? So trachea and esophagus are there. So routinely what happens is the tongue lies here. So therefore oxygen starts from here, goes here, and carbon dioxide comes out from here and moves away. When someone collapses, guys, the tongue which is there, it falls at the posterior pharyngeal wall. And now you see it blocks the passage of air. So even if you want to give a mouth-to-mouth breathing, if I want to give a breath to the patient from here, the tongue is obstructing it. So somehow or the other, the obstruction has to be removed. So sometimes it's not just the tongue. Sometimes there may be a foreign body lodged over here. So therefore, the point is that straight away chest compression and breath, you don't do it. You first have the A. You need to open the airway, or you need to remove the obstruction of the airway. So now the breath can be given. So remember, A and B are together. C stands for chest compression, but A and B are together. You need to first open the airway. You need to remove the obstruction which is there, and most commonly it is the tongue. If it is not the tongue, in that case, it can be a foreign body. So first chest compression is 30 chest compression, 2 breaths. But before you give the breath, guys, you need to remove out any obstruction which is there. If it is a foreign body, you take it off. If it is a vomiters, you take it off. You put your finger inside, take it off. And if not, if the tongue fallen back, then in that case, you need to do a head tilt chin lift. Okay, so this maneuver becomes something to open the airway, so that once the airway is open, now your breath can go inside. Open the airway. Okay, head tilt chin lift. So head tilt chin lift, and you see in this case the neck is moving. So this head tilt chin lift is contraindicated in fracture cervical spine. In fracture cervical spine, what you go for is jaw thrust. So a lot of people then say head tilt chin lift jaw thrust is what is called as triple maneuver. But normally the point is you are supposed to do them separately most of the times. Head tilt chin lift is one point, and jaw thrust is what is included in basically someone having a fracture cervical spine, where you should not be moving the neck of the patient. But all the three can be combined in a patient not having fracture cervical spine, which is called triple maneuver. Clear? Hopefully this is okay. Next question. Again, there were doubts on this. Some people said, sir, tracheostomy image was given. Some people said, sir, tracheostomy image was not given. Some people said, sir, 2 images were given. Some people said, sir, no, one tracheostomy image was given, one was not given. So even I don't know how many tracheostomy images came. Let's discuss the one which most commonly the students have said, which has an anesthesia component onto it. And the question was, which of the following is not a use of the device shown in the image? So acute airway, upper airway obstruction, upper airway assessment, pulmonary lavage, and prolonged mechanical ventilation. So the device shown was tracheostomy. In case the device was not given, the answer would be, what is not the use of a tracheostomy? So the point is, when you do a tracheostomy of a patient, the first thing is that it is a channel for oxygen to go in and CO2 to come out, right? Which means you're trying to remove an obstruction, which means someone had an upper airway obstruction, oxygen is not going in, CO2 is not coming out. Instead of intubating also, you felt better to put a tracheostomy. So by doing a tracheostomy, what happened? You are providing a channel for oxygen to go in, CO2 to come out, and thereby if there was an obstruction, it got relieved. So therefore, acute airway obstruction is a use. It is a use, right? Upper airway assessment. So if you want to assess the upper airway of the patient, assess means you want to look at the airway. You want to assess the patient's airway. You just want to look at the airway. You're not doing anything. Imagine you want to look at someone's airway and you take a tracheostomy, you say, chal mukh khol, thak. Can you do that? Look at the words, na. You just want to do upper airway assessment. You want to assess someone's upper airway. Upper airway means here, above the glottis you want to see. So the same patient is there. I want to assess his upper airway, somewhere here. I want to assess this point, upper airway. And I tell him, chal, I want to assess means I want to have a good look at the upper airway, if there's some problem or not. So I say, chalo, let me put a tracheostomy tube. Can I do that? No, yaar. If you want to look at the upper airway, remember the most important investigation was Malam Patti. Assessment of the upper airway, Malam Patti classification, Malam Patti 1, Malam Patti 2, Malam Patti 3, Malam Patti 4. This is what tells you. It tells you about visualizing the posterior pharyngeal structures, by which it tells you the laryngoscopic grading and the ease of intubation. We have discussed these points out, right? This is what is done for airway assessment. So mouth opening, Malam Patti examination, thyromental distance, sternomental distance, right? Neck movement. So these are all the points which are used for upper airway assessment or assessment of the airway. Putting a tracheostomy tube is not an assessment of the airway. It is to do some procedure, right? For some reason you put it. So straight away, if you go for it, remember this point that upper airway assessment is wrong. It is not a use. So here the correct answer would be B. I would go for B. Upper airway assessment is where you will do Malam Patti examination, you'll do neck movements, right? You will go ahead with thyromental distance, sternomental distance. You will look at any mass, beard, or something of that sort. Any teeth which are loose. That is what I'm going to look at the upper airway assessment. So upper airway obstruction, for relieving that, yes, you will use a tracheostomy, because if someone has upper airway obstruction, you will put a tracheostomy tube to relieve it. Third point here was pulmonary lavage. So pulmonary lavage is pulmonary suction, basically doing a suction, basically doing a toileting. Someone is unable to cough out a secretion, or something is left inside the lungs. You want to just clear it out. So of course you're using a suctioning for that. So many times, normally if a patient is admitted in the ICU for short-term ventilation, we put an endotracheal tube which goes here. But an endotracheal tube can be kept maximum for 7 days. At the maximum, we keep it for 10 days. But if we expect the patient to be more than 10 days, then we put in a tracheostomy in the patient. What happens with the tracheostomy? The suctioning becomes much more easy. The maintenance becomes much more easy. And that's exactly why tracheostomy is done in ICUs. Which will bring me to the next question, guys. That's how integrated questions have come this time around. Okay. So tracheostomy, yes, it is used for that suctioning. It is used for that, lavage that you say. So pulmonary lavage or pulmonary toilet is what we use it. And of course, I discussed here itself right now that, if there is a prolonged mechanical ventilation, which means in case a patient was to be ventilated just for 7 to 8 days or 10 days, I can put an endotracheal tube in the ICU and ventilate. However, if it becomes 15 days, 20 days, expect like a tetanus patient. If I know if it's a tetanus patient who's going to be on a ventilator for about 18, 20 days, anything between 10 to 20 days, I will rather go in for a tracheostomy, which is easy to maintain, easy to suction, and taking care of the patient's airway much more better manner than endotracheal tube. Okay, so this is the point here. All the three are uses. Acute upper airway obstruction, yes, you will use it for that. Pulmonary lavage also, prolonged mechanical ventilation. But upper airway assessment is the odd one out, wrong. Okay, it is not the use, upper airway assessment. Based on the same thing, when students said, sir, tracheostomy 2 questions, tracheostomy 2 questions, next question, right? This was the question. Identified the adjoining image. Now, Dr. Jagdish will get angry at me, but I can't do it. I told him I've stolen things from here and there to make it anesthesia also, because we do it in anesthesia, by the way, guys. Even I have done it. Okay, if it is the same thing. If I am wrong, kindly correct me in the box, the answer box below. You guys can correct me that, right? So Dr. Jagdish will also take it. But let me discuss this point out. Identify the adjoining image. The 4 options given were percutaneous tracheostomy, classical tracheostomy, partial laryngectomy, and total laryngectomy. So laryngectomy, according to me, is out. As I said, I may be wrong. Dr. Jagdish will say it correctly, so that you people can go through that. Classical tracheostomy, according to me, is when you are cutting the rings here, and maybe probably, you'll have a window like this, a flap removed this way. Here is more of what we have done in the ICU. And I'm saying it because even we have done in the ICU when we were working for a long time in the, when we are part of the ICU unit in Delhi also, I'm saying, like Wallah Medical College, I've worked over there, and we have done lots of percutaneous tracheostomy. So it's not just that the ENT people do tracheostomy. Yes, ENT people are doing the classical. I've never done a classical tracheostomy, but percutaneous tracheostomy even I've done. Problem is, because the patients get admitted in the ICU, we do the percutaneous tracheostomy, and after that follow-up, we don't do it, right? Follow, then the patient follows up with the original ENT person, or whichever branch the patient was going into. So percutaneous tracheostomy, even I have done in case of an when we had to do in the ICU, and this normally should be, according to me, percutaneous tracheostomy. I may be wrong, but still I've included the point. See, if you're wrong, doesn't mean that it's a bad thing. One may be wrong otherwise also, but if there's a question, why not discuss it out? So according to me, this should have been percutaneous tracheostomy, because tracheostomy is like this. Percutaneous is what looks like this. If you are using a cylindrical technique, the slit type goes like this, and the flap one goes like this, which I was talking about, where you're cutting the rings properly, right? This is the percutaneous tracheostomy set which we do, and this technique is the same technique by which we put the central line. It is called Seldinger technique. Seldinger technique is like, when you try to take one needle, you take this needle and syringe, you try to find out the right space from there, and then what you do is you withdraw the syringe and you take these dilators. From the dilator, what you do is try to put the dilator from there, right? Then you put the guide wire. So what you've done, basically, you've taken the needle, the syringe. So this is the first step. You take the needle and the syringe. So once you identified that you are correctly placed in the trachea, the next step would be to use a guide wire, right? So what you can do is use this scalpel, make a small cut around there, and you put the guide wire. Over the guide wire, then you put this dilator. Using the dilator, what happens, that hole over that you see, that small opening that you see, this gets opened up further, and it will become of this size. And from there, then what you do is you put the tracheostomy tube. So these are the 4 steps, and this is called as Seldinger technique. And this Seldinger technique is also used for putting the central line. This is exactly what we do when we put a central line also, Seldinger technique, right? And the same technique, I think so. If I'm wrong, please guys correct me, right? I may be wrong also, as I'm saying. And this is what I know. I'm just sharing my knowledge with you. There's no one who can say I know everything. Every day is a learning experience for me and you. If I'm wrong, I'll be learning from you also, right? There's no harm in learning. There's no age to stop learning. But there's no harm in answering also. Even if I'm answering wrong, what's the harm? I'm just sharing my knowledge with you. So according to me, this is how it is done. First step is using a syringe and needle. Second step is then you put after identifying the space, you put a guide wire. After the guide wire, you put a dilator. After the dilator, you put a tracheostomy tube. right? And of course, there has to be a small cut has to be given around so that the tracheostomy tube can slide inside properly. And this according should be the answer should be percutaneous tracheostomy. So I discussed so many questions which are relevant to anesthesia as well, because this is what even I have done, being a part of anesthesiology and not being a part of ENT. So percutaneous tracheostomy, anyone who has worked in the ICU has done it. So all of us who have worked in the ICU, anesthesia people, we work in the ICU day in and day out. So even I have done percutaneous tracheostomy, right? So according to me, the question answer here was percutaneous tracheostomy, hence I included that also. But yes, ENT people will discuss it much further in a better manner, and we'll go ahead and discuss with you other types as well. One question I didn't discuss at all, right? And thanks, Dr. Sandeep will say thanks to me then. The point is, I have not included that EVM. What is that? Glasgow Coma Scale. So that Glasgow Coma Scale was also asked, but yes, that becomes a directly surgery question only. You're there in the casualty. So I have not included that, though Glasgow Coma Scale also becomes a part of anesthesia, right? So that question was that E2, V4, M3, I think. I think that was the correct answer for that. I'm not very sure. Eye-opening verbal commands and, movement which is there. So this was the GCS score. That question I have not included over there. So these were the questions that I discussed. Hopefully this session was of some help to you. Thank you guys for joining me at this session. Thank you. Oh, one more question. I thought it is gone. Okay. Best antibiotic for surgical antibiotic prophylaxis during cardiac surgery. Oh, I thought I've not included this, but I included this also, right? So again, this answer is very simple. You tell me. Correct. So is it cefazolin, penicillin, doxycycline, vancomycin? I think vancomycin was not given, but I think cefazolin, penicillin, doxycycline was given. This is proper surgery question with pharmac question, anesthesia question, because that to cardiac surgery, right? Pharmac is a medicine and the anesthesia people are the ones who give it inside the OT. Again, it becomes a integrated question, guys. Correct answer here is cefazolin. Cefazolin is the antibiotic which they say is the one which is supposed to be the best for surgical antibiotic prophylaxis during cardiac surgery, prevents the infections, right? So thank you guys, thank you so much for joining me, right? Thank you.